pretty much the same, but thank you once again for having me. I just want to point out my slides, as you can see, says 75 years. I'm here representing our association, our Mexican Association for Reproductive Medicine, and it's with pride I say that we just turned 75 years of age. So thank you once again for having me and allowing me to share with you our experience with using different strategies to trigger the final maturation of oocytes. So this slide enlists the most important effects induced by the natural LH and FSH peak. This is actually a question that I ask my fellows, and it's very important to understand every single one of these effects induced by the LH peak. And these are different strategies with the use of GnRH agonists. We know that this is a strategy employed initially for patients that are high responders. However, we have modified this strategy when we use exclusively the GnRH agonist. We know that this decreases the risk of OHSS. And if we do plan a transfer in that cycle, it's very important to administer a very intense luteal phase support. Another option is adding HCG, for example, the day of the VOR, the day of the retrieval, or a few days later in case of performing a fresh embryo transfer for luteal phase support. And then the dual trigger, which involves the administration of the GnRH agonist plus HCG. And the reason behind giving those both medications is the theoretical impact on improving the oocyte maturation prior to the oocyte retrieval, and plus allowing a sustained support of the corpus luteums. And then there's this other strategy, which is a double trigger option for patients who have a low maturity rate, and we'll review very shortly what this double trigger consists of. So the importance of inducing this LH surge with an agonist is that with the agonist, we obtain also that FSH peak that when we trigger only with HCG, we do not have. So FSH, along with LH, but specifically FSH, has a role in increasing the plasminogen activator activity in granulosa cells, which disassociates the oocyte from the follicular wall and weakens the wall. So in theory, it improves the oocyte recovery rate. The number of oocytes retrieved is increased when elevated FSH levels in the follicular fluid. Additionally, opening of gap junctions between the oocyte and the cumulus cells improves. So this, again, allows us to retrieve that egg. And there is an impact on nuclear maturation and cumulus expansion as well. This is a study published a few years ago in which the granulosa cell gene expression was evaluated in oocytes obtained with HCG trigger versus dual trigger or double trigger. And what the authors found was that the double trigger was associated with the greater expression of amphiregulin and epiregulin and lower expression of connexin 43. The amphiregulin is a ligand for the epidermal growth factor receptor, which is responsible for intracellular signals of cell survival and proliferation. The first report of using a GnRH agonist instead of HCG was in an ASRM meeting in 1988. It was published in 1999, later on by Iskovits. But they used the GnRH agonist trigger instead of HCG in patients with high response and normal response. They report 4 pregnancies and no cases of OHSS with good fertilization and cleavage rates as well. And in 2018, the addition of HCG in patients that are high responders was reported. And this was a group of patients, on average, 45 patients on average, 30 years of age. They were all high responders, and they all underwent a fresh transfer. So again, the addition of HCG may have a role in assisting the oocyte maturation process prior to egg retrieval, and it allows us to sustain the luteal phase support. They reported implantation rates of 47.5%. And then when when authors have compared the effect of only triggering with HCG versus dual trigger, this is a report in 2014. 120 patients were randomized, demographically similar in both groups. they reported a greater number of top quality embryos and embryos available for cryopreservation with the dual trigger compared to HCG alone. And then there have also been reports in which patients undergo first retrieval with HCG, and less than 25% of the oocytes are mature. And then they undergo a second retrieval with dual trigger. And as you can see, a greater amount of mature oocytes were reported with the dual trigger. So we can go on and on. There's so many publications related to this. And so if we look into the meta-analysis and randomized controlled trials comparing the dual trigger with comparisons of HCG alone, this included 1,000 patients, 8 studies, and you can see that in this meta-analysis there is improved results in terms of the number of eggs collected, mature eggs collected, fertilized oocytes, usable embryos, even a trend towards better or improved live birth rates, clinical pregnancy rates, and ongoing pregnancy rates, as well as implantation rates. And how about using dual trigger in poor responder patients? This was a publication from a few years ago. Close to 300 patients were included. Half of the patients were triggered with dual trigger, the other half with HCG. These are patients with an extremely low ovarian reserve with AMH levels below 0.5. An average age of 40 years. And you can see as well that the dual trigger was associated to a greater number of oocytes retrieved, metaphase 2, and fertilized oocytes, as well as a significantly greater number of day 3 embryos available and top quality embryos available in dual trigger. They also report improved implantation rates, clinical pregnancy rates, and live birth rates with dual trigger. And the meta-analysis for these low responder patients also demonstrate improvement in terms of pregnancy rates and live birth rates with the dual triggers. And so as I mentioned, we can go on, and there are so many publications related to the efficacy of dual trigger, especially in poor responder patients. The question is, should we use this trigger strategy to all patients? Especially there's a place for patients who are high responders and normal responders. We have to keep in mind that the addition of HCG, a small amount of HCG, has the benefit of there may be patients who will not respond to the GnRH agonist trigger. So we have to keep that in mind. We may have high responders who have hypothalamic amenorrhea, and hence they won't have an elevation in their LH level after the GnRH agonist trigger. There are patients with polymorphisms on the GnRH receptor as well as polymorphisms on the LH receptor. And so these patients may not respond adequately to that GnRH agonist trigger shot. Also patients, for example, who have been on oral contraceptive pills for a long period of time, who have LH levels below 2 at the start of gonadotropins, or even low LH levels the day of the trigger, LH levels below 15 the day after the trigger, prolonged stimulations. All of these are risk factors for patients who may not have an optimal response to the GnRH agonist triggers. So adding a little bit of HCG may be beneficial, and this way we avoid encountering that risk with these patients. The double trigger option is an option that has a place for patients who have a low maturity rate, and the GnRH agonist is administered 40 hours before the retrieval, and HCG is administered 34 hours before the retrieval. So the prolonged effect of that GnRH agonist may have a positive effect or an improvement in terms of the maturity rate with these patients. So we know the empty follicle syndrome, the genuine empty follicle syndrome is extremely low. This means that those patients applied their medication adequately, they applied the agonist, the HCG, and despite that, we don't retrieve oocytes. The false empty follicle syndrome are patients who just don't respond adequately to the trigger shot. So this is one of the reasons why after the trigger, we routinely always measure LH and HCG if it was a dual trigger. And so again, Raul Orvieto published this a few years ago, and they performed this pilot study in which A very limited number of patients were triggered with HCG, GnRH agonist, and double trigger. And you can see here that they report a higher ongoing pregnancy rate in patients receiving the double trigger shot. Now, these are patients with a very limited prognosis, with a severely diminished ovarian reserve. And this other publication from 2021 includes patients, 13 patients that underwent a first retrieval with no oocytes, and then a second retrieval employing the double trigger strategy. And there's a very notable improvement in terms of the number of oocytes retrieved, and of course, the clinical pregnancy rates and the live birth rates. So our experience, we presented this at ASRM a few years ago, in which close to 2,000 patients were included, and we analyzed the outcome of patients who were triggered only with GnRH agonist versus dual trigger versus recombinant HCG versus urinary HCG. And we noticed a greater percentage of maturity with the last 3 trigger strategies. Although 59 versus 63% is really not that different, but given the numbers of patients, we did encounter a statistical significance. And then when we analyzed the aneuploidy rates by these different trigger strategies, we did not find any difference in terms of euploidy rates with embryos. Between 2010 and 2016, in our practice, we would perform a day 5 day 5 biopsy and use real-time PCR, and then receive results within 4 hours, and then transfer on day 6. So this allowed us to perform fresh transfers with euploid embryos. So we reported over 2,000 transfers, in which patients were triggered dually using 2 milligrams of leuprolide and 1,000 units of HCG. And we stratified patients based on the estradiol levels, less than 3,000 picograms a day of the trigger, 3,000 to 5,000 picograms in the second group, greater than 5,000 picograms of estradiol in the third group. And what's noticeable here is that basically the clinical, the fertilization rates were not different. The clinical pregnancy rates, given that we were doing fresh transfers were lower for patients who had greater than 3,000 picograms of estradiol, which was something completely explainable because of the hyperestrogenism effect on the endometrium. But we really reported not too many cases of moderate OHSS. You can see in patients that were triggered with more than 5,000 picograms. There were 5 patients out of 40 who developed moderate symptoms. And then with dual versus double trigger, we have a limited case report. Each one of these rows represents a patient. The first row in bright blue are patients who underwent dual trigger, and then they underwent a second cycle, and we performed a double trigger in these patients. And as you can see, we really did not notice that much of a difference in terms of the rate of maturity, except for one patient, which was patient number 4. In the first cycle, it was patient number 2, in which in the first cycle, there were 6 eggs retrieved that were mature. In the second cycle, 8 eggs that were retrieved. But when we look at the blastulation rates, we really didn't notice any improvement in blastulation rates. As a matter of fact, in that same patient, we noticed a lower blastulation rate with the double trigger. So this was a rather puzzling for us. We expected better results with the double trigger. Again, these were patients in which we wanted to improve the maturity rates, and we were surprised not to see an improvement. What we did learn, however, is that again, these patients have to be triggered early. We did have many patients who by the time we reached the retrieval, we had 1 or 2 corpus luteum. So these patients, as mentioned previously, are at a higher risk of premature ovulation. So one of the recommendations, if you do double trigger, is to trigger these patients with smaller follicle sizes, especially because of the prolonged effect of the GnRH agonist. So this is my last slide. Again, just the disadvantages of doing a dual trigger. We need to monitor post-trigger hormonal levels just to ensure and determine whether we need to add more HCG prior to the retrieval. Some patients are not candidates for this option. The advantages are many, as proven with all the publications that I mentioned. And with that, I want to thank you for your attention.